You so much for the kind invitation to this wonderful worldly international meeting on heart failure therapies. I am very delighted to bring a topic close to my heart, the emerging therapies and algorithms for heart failure. But I also want to take a moment of your time to really thank you for doing what you do, being first line responders, working in the hospitals, and taking care of patients during this pandemic. It has brought us closer together than anything ever has in mankind, at least in recent recollection. So again, I think topics such as heart failure are very important because they continue to allow us to advance the therapies for morbidity and mortality reduction. And again, it is my pleasure and honor to bring a topic dear to my heart in order to hopefully advance our arena of heart failure to improve those therapies for these patients as well. I am Deйл Yu. I come from Dallas, Texas, in the United States. I am a cardiac electrophysiologist with close ties and passion for heart failure therapies. And again, am delighted to bring you this topic today. Here are my disclosures. Overall, a couple of slides to really introduce you to the impact of heart failure and what it really does mean. It doesn't really matter what country in the world that you are in. It directly impacts us and our loved ones and the patients we see every day. We understand that heart failure comes in many different forms, and often acute heart failure is what we see in the hospital, but chronic heart failure is the issue that we face on a day-to-day basis, especially from our clinics. We know that we start asymptomatically in New York Heart Association Class 1, and then over time, we do progress rapidly between the different stages as these things can change, not only on a daily basis, but really hour to hour. Our goal ultimately is to minimize these collapses in heart failure exacerbations, as I call it. We really want to minimize the number of times that we are hospitalized and minimize the number of times that we have to be on acute changes of medications in order to bring us back to our normal. As we know that as each one of these humps occur, it brings us closer and closer to a state that is closer to death than that of life itself. It provides a very huge burden to the economic barriers around the world, not only in the US, but all over the globe. It has an impact that's so great that it's the largest part of our healthcare dollars spent from the GDP. In the United States, is the number one cause of hospitalization for all patients over 65. It is also the number one cause of hospitalization in the entire developed world. Total cost of heart failure in the United States alone is projected to be almost $100 billion in the next 10 years. We know that a quarter of these patients are readmitted within the first 30 days of initial hospitalization, and over half of them are readmitted within 6 months. And the United States hospitals lose on average of about $1.2 thousand per admission that each patient comes to the hospital with. Despite medical advances, heart failure hospitalization is worsening and continues to be an epidemic as well. There's significant reduction in coronary deaths. However, there's a significant increase in heart failure hospitalizations. It is actually the number of hospitalizations with heart failure as it goes up that increases the mortality rate as well. Again, looking at the goal of heart failure management, we want to slow disease progression by preventing decompensation. We also know that each event accelerates the downward spiral of myocardial function. So with each subsequent heart failure-related admission, a patient leaves the hospital with a further decrease in their cardiac function in itself, as we again approach a state where we're so morbid that we are bedbound and then again very close to death itself. Our ultimate goal is to maintain fluid volume changes to avoid acute decompensation and hospitalization using proven drug and device therapies. This is one of my favorite slides because as an engineer by trade, it's a passion of mine to determine why heart failure occurs from a mechanistic standpoint and a physiologic standpoint. And this slide really illustrates the complexity of the actual physiology that it takes for the heart to actually contract. And so when weakness occurs, it doesn't occur in one plane, it's occurring in 3 dimensions because there is the twisting action of the heart, the twisting action of the cone in itself, twists one direction for contraction, and it untwists in another direction as it relaxes. So, of course, this three-dimensional twisting and unloading action makes it very difficult to understand how exactly we can benefit it from a mechanistic standpoint when we're talking about device therapy. We all are trying to elicit the best possible response for each patient. Ultimately, taking patients that don't respond to therapies that are state of the art, such as CRT, make them potentially responders, and if we're lucky, make them super responders. Of an algorithm that I've kind of come up with over the last decade or two is a simple one in determining how this patient who is ultimately on a biventricular or has a biventricular device inside you, but is still decompensated, understand why that's occurring and what next to do as they are having state-of-the-art equipment and therapies done for them. Simple thing is always to check a 2-view x-ray. I like to also make sure that the EKG shows that the QRS is as narrow as possible. We also do device interrogation to make sure that biventricular pacing is above 95% and that it's done in a timely way. We often want to look at other modalities in terms of being able to optimize that, potentially with echocardiograms if we can do that as well. We also want to check the actual lead positions. After looking at an x-ray, if we happen to be in the operative suite or the EP lab, and we're actually going to modify this patient's lead positioning, we want to see where it is, and we want to identify a place where it could be better, understanding that electrical separation with QLV is much more important than anatomic location. Also understanding what kind of leads that there are on the system, whether or not you planted them or not. We want to know what we have, what is our hardware, and what is out there, and which one is the best. Is it a bipolar lead? Is it a quadpolar lead? And who knows, in the near future, we may have octopolar leads. The more leads aren't necessarily the better thing, and the more electrodes not necessarily a better thing, but the having more options is a better thing. It allows us to find exactly what is necessary and best for that particular patient. We'll get into it in a few slides, but ultimately there are many algorithms that have come out recently to also help us maximize the efforts that CRT technology has been able to bring our patients over the last couple of decades. That includes both multi-point and sync AV or adaptive CRT from a Medtronic standpoint as well. There's also non-CRT therapies out there. I have had the pleasure and honor of being able to teach in numerous countries over the last several years for APAC and other societies. While doing that, I've really had my eyes really opened wide as I see what's available. It's not always biventricular therapies that are available. Not only that it isn't physically available, but from an economic state and status standpoint, the patient and their family could not afford it. So therefore, pacemakers, the basic varieties are what is left, which has brought us closer and closer to the two hot topics lately, which is his pacing and left bundle branch pacing. And I know that at least his pacing therapies are being discussed at this conference. And I feel it is a very important topic to do so, as this may be an alternative method of reducing heart failure and treating it without necessarily putting a biventricular device in place. As mentioned above, anatomic placement is ineffective for finding the best spot. And when we're looking at the MADED CRT trial, we saw that it didn't matter if physiologically or anatomically it'll look like this is going to give you the physiologic best location, because there was a nice middle or high lateral location that looked like it was separated by quite the distance to the RV apex where the lead of the RV lead is. But ultimately, knowing that that separation exists is not enough to give us what we're trying to achieve, which is the ultimate optimization and synchronization of CRT. So what we have found is increasing electrical delays and finding a QLV is actually more suitable and more efficient in terms of finding optimal sites for synchronization. When we look at QLV, again, the electrical delay between the RV lead and the LV lead, kind of looking back at that slide we talked about, the engineering slide, about the unloading and loading of the conical heart. When you understand that, you also will understand that there is anisotropic conduction, and that often will affect which strands and which muscle fibers, which plane will contract. And then if you want to complicate that further, When you have intramyocardial scar, whether it's something due to a genetic abnormality, or if it's an infiltrative disease, or if it's from myocardial infarction, an infarct from the past that causes a true structural barrier there, it doesn't really matter. But understanding that there are so many different ways that cause these barriers, physiologically speaking, just looking at an x-ray or looking at a fluoroscopy often is not enough. You need to understand that these barriers may make it so that electrical conduction has to go way around the corner in order to get back to where it needs to go. And that's unpredictable when looking at an x-ray. Also, looking at the slide, I want you to appreciate the fact that the longer the QLV, the better the ultimate outcome. And that makes sense because the ultimate QLV would suggest that there is severe electrical dissociation, hence synchronization is out of place. If you can get your QLV over 120 milliseconds, that gives you the best response. Actually, a QOL response, quality of life response, nearing 70% or just over 70%. Your LV end systolic volume also responds to this as well, showing that there is remodeling potential when you do fix these synchronization issues. When you are above 120 milliseconds with a QLV, you have a left ventricular end systolic volume response rate of 68% as well. So I think I've belabored the point, but just to really drive this point home, because I think it's an important one, CRT therapies, which has to date been the gold therapy or platinum therapy for heart failure patients that have been refractory to medications, understanding that it is not purely mathematical and not purely visual, as we mentioned earlier. And as such, we have other reasons why we need other ways to help us manage it. And this kind of brings us into the world of algorithms. We kind of touched on it earlier, but changes in intrinsic activation, scar, block, whether it's absolute or functional, and conduction variables in our anisotropic conduction, these are all complex factors to take into place when we're talking about optimization of therapies. So I'd like to start with multi-point pacing, as this was one of the first landmark, really, trials and therapies that came out in terms of algorithmic ability to help CRT patients that are non-responding. That's a mouthful. But the goals of multi-point pacing really is to pace from 2 LV sites separately and actually contracting the tissue that's closest to it. That recruits more tissue altogether and suggests that you can synchronize the tissues better as well. This hopefully will improve the pattern of depolarization, hopefully will engage areas around the scar tissue, improve hemodynamics, and as I said before, resynchronization depends on this as well. So when you ask yourself, can multi-point pacing improve response in patients receiving conventional CRT? Well, there have been some studies, several that have been very small, but ultimately asking this question and immediately responding with a yes really opens your eyes, because what it tells you is that not only physiologically can we help the heart and heart failure with putting in new hardware and leads and putting them in different places, we can also activate algorithms that are also able to help us. So when you look at this trial, the small trial looking at the patients with conventional CRT, and then 12 months out, adding multi-point pacing algorithms on, what you saw are the patients that improved more. Patients who didn't improve, improved at that time. So it suggests that patients that even after remodeling can benefit further with algorithmic changes such as this. Also understanding that there was a vast improvement in New York Heart Association class, as well as left ventricular end systolic volume. And ultimately, that's reflective in ejection fraction as well. So going back to our motto, or I guess our desire in terms of helping heart failure patients, we want to convert non-responders to responders in the shortest amount of time as possible. Looking at another study of 506 patients, we took patients that had traditional BiV implants. We did this for 3 months. We also evaluated their echoes and determined to see if there was much improvement with CRT. We randomized them to be able to have traditional BiV versus having the multi-point algorithm turned on. When you look at that, when not only if they had multi-point pacing on, and we also separated that group into those that had farther separation of the two sites that were activated, and also a delay between activation between the two sites allow for sequential twisting of the heart. You saw that you had a 100% responder rate if you allowed for more than 30 millimeter separation between the two sites, and a delay of 5 milliseconds, which is very small, but enough to allow you to have these wonderful benefits. And when you bring the Frank Starling curve in and start looking at pressure volume loops, what you'll notice is you actually have remodeling. An entire conformational change allows you to shift that whole curve from one side to the other. The benefit you get is not only acute, also chronic, but it also changes various parts of this curve, and you can see the improvements because of the algorithm in itself. The second algorithm I'd like to talk about is SYNC-AV, analogous in many ways to adaptive CRT as well, which I'll talk about within this. One of them is from Abbott, that's the SYNC-AV, and Medtronic has the adaptive CRT, both revolutionary algorithms that allow for not only synchronization between different sites of muscle in the ventricles, but also allowing for native conduction from top to bottom to help us fuse that to synchronization of the ventricles as well. It's a novel idea, and honestly, a wonderful one at that. And of course, not necessarily one that can be done in complete heart failure patients, but for our majority of our patients who don't have complete heart block, but have heart failure, they would benefit from this. So understanding that there definitely is value in allowing for delivery of fusion of conduction from your native conduction system, whether or not it's left bundle branch block or right, but mostly left bundle benefits more, and fusing this to contraction that's forced and timed from the bottom chamber as well. When you take a look at this, and when take a look at the SYNC-AV algorithm and understanding why it would work, we're essentially fusing it from top to bottom, left to right, back to front. As I said, the heart is a three-dimensional structure, and maximizing its efforts from three different dimensions will hopefully give us the best outcomes, as these studies have said. CRT in itself has been wonderful over the decades that we've had it to us, but it really pales in comparison to what we should be able to achieve with the therapies, algorithms, and technologies we have these days. Also understand that QRS abbreviation is not always ubiquitous with nominal programming, which is out-of-the-box programming that we often see, but it is facilitated by an automatic dynamic device-based algorithm to accommodate variability, as there is intrinsic AV interval delays and changes with time, hormones, again, electrolytes, and potentially even physiological changes. For example, if you're just waking up from bed, your AV delays may be longer, and if you're going to go run up the stairs or run in a marathon or go outside and just do your normal exercise, you'd expect that to narrow up as you have to increase the heart rate, and those refractory periods are also going to button up and get smaller. So understanding that and integrating that physiologic change is also very important, which is what SYNC-AV has been able to do. To bring back adaptive CRT, there are two commercially available algorithms that allow the periodic repetitive adjustments of the CRT pacing according to, again, the intrinsic AV conduction systems that we talked about. The few differences are here. Adaptive CRT preferentially delivers LV fusion pacing and is restricted to patients with PR intervals of less than 200 milliseconds. And it also does not permit individual programming. It is the first algorithm that did come out along these lines. And usually the first ones are the ones that may make a huge splash in the waters. But we like to think as further algorithms come out, second ones, third ones, and fourth ones, that we do a better job optimizing those algorithms as well. And I believe SYNC-AV did a good job with that. Knowing that SYNC-AV permits biventricular and left ventricular pacing and seeing which one's better, and also allowing for some wide AV programmability, as it does allow for patients to have first-degree AV blocks all the way up to 300 milliseconds as well. And also works to make a check every 256 beats. It extends the pace and sends AV delays for 3 beats, and then measures again to make sure it is optimized for that physiologic change at that time. When you look at multi-center meta-analysis and SYNC-AV, what you'll notice is that it isn't the LV fusion pacing or LV only that is the best. And in fact, this was done because adaptive CRT had shown that LV fusion pacing was so wonderful and amazing, which it still is. But to take that one step further and figure out which type of pacing algorithm would help the best, that was done with this meta-analysis. And as you can quickly see here, the best one was with bi-V pacing and SYNC-AV algorithms that were optimal, not necessarily predefined set at 50 milliseconds out of the box. This study also showed a nice effect not only on the ischemic cardiomyopathy population, but also non-ischemics, which is an area always in hot contention, is we're not always certain to know how they behaved, how they got there, and if they're going to benefit as much as the patients that had ischemic heart failure in itself. When you take a look at the distribution again more in detail, what you'll notice is that one group, Group 3, the one that did bi-V pacing and optimizing the AV delays to allow for the best bang for your buck, as so to speak, what you'll notice is there also was not one patient in that group that actually did worse in terms of the QRS shrinking. QRS duration was less in every single patient. However, in all the other groups, whether it's LV fusion or just bi-V pacing with an out-of-the-box 50 millisecond AV delay, regardless of what that is, there was at least 1, 2, 3, or 4 patients in each of these other groups that did worse with the program, which is often something we see in clinic. We think we did the best we can, and then once in a blue moon, you'll have a patient that actually does worse, and you have to turn off the LV lead. So that brings us to other types of pacing algorithms, not really algorithms as much as methodologies. His pacing, again, has been around for quite a while, but in recent years has come more in vogue, and something that I've done as well. And I think with the His Pro sheet from Abbott, we're going to have a revolutionary change and shift in our thought process when we bring patients to the lab that are on borderline heart failure or that have heart failure, and we want to determine how best to treat them. Understanding, and again, I appreciate the other talks at this conference highlighting the importance of his pacing, especially as we learn more and more about it. When we pace with his pacing, we do want to have selective capture as opposed to non-selective capture. However, talking to my colleagues and experts in this field, we still will settle on non-selective capture, as we do believe that's still better than having none of that and doing traditional RV pacing with a huge QRS widening as well as dysynchrony from the RV pacing in itself. What we tried to surmise as a mechanism, which is also up for debate in some arenas, is due to a few different thought processes. One is reversal due to distal pacing that allows you to bypass the bundle that's broken. Another one is reversal due to remote electrical activation. And then lastly is one that's due to close proximity to a high septal branch. Enough energy comes out that you're capturing pretty much everything around it as well. Left bundle branch pacing is another methodology, taking his pacing to one more step further. I know in a couple of countries I've visited, this has become quite popular, including China and India a little bit more as well. It obviously makes sense in that patient that has left bundle branch block is not a candidate or either financially or mechanistically for biventricular pacing to do left bundle branch pacing and proving that there is benefit with resynchronization and narrowing of the QRS to normal QRS. It definitely is an area that has piqued my interest and an area that I want to learn more about. As I've seen it, I've been able to be part of it and plant it as well. I still think there's a lot we need to know in terms of the safety, its dislodgement, its burrowing into the left ventricle, potential scarring in that area. There are things that we don't know yet, but we do know on the times that we've done it and those hands that are good at doing it, that it does narrow that QRS quite substantially and has shown positive reinforcements in terms of remodeling of the heart as well. So before moving on to just two other things for heart failure, emerging technologies, and so on and so forth, I want to start with a case study that will illustrate the point for me as well. So you take a 62-year-old female with non-ischemic cardiomyopathy, diagnosed about 4 years prior with the traditional risk factors we see: paroxysmal atrial fibrillation, hypertension. Is hospitalized quite a bit every year. Has a dual chamber ICD implanted. The QRS wasn't wide enough at the time. However, followed by AFib ablation 6 months later, noticed that there was the left bundle branch block, did well for 12 months, but then had more AFib, and that exacerbated the heart failure issues as well. We ultimately did an AV node ablation and did a CRT-D upgrade, and overall, the symptoms did improve, no hospitalizations initially, but after about 4 months, there was finally a hospitalization, and again for heart failure with New York Heart Association Class 3 symptoms. We tried multiple AV and VV optimizations. We also had them on Merlin. We're watching them very closely, like a hawk. We had frequent clinic follow-ups and device checks. Despite all this, we couldn't stop this patient from getting admitted more than one time to the hospital that same year. So this is what we did, ultimately. What is this? You might ask yourself. Those that have implanted it or are familiar with the literature, you will note this as a CardioMEMS device, which I'll get into in a few slides. Current heart failure management, as we talked about, is not great. And there's a lot of reasons for that as well. And a large part of that has to do with the fact that we are trained to use symptoms and also technology and tests, labs, diagnostics, in order to help us determine what's the best way to help our patients out. However, symptoms are still one of the largest things we utilize. But the problem is, by the time you get to symptoms, you have already reached a point sometimes of no return. Decompensation is just right around the corner. You may not be able to right that ship after it's hit the iceberg. So what are some of the symptomatologic things we utilize in order to help our heart failure management? Well, they include JVP, they include hepatojugular reflex, they include listening for an S3, listening for RALs in the lungs. Taking a daily weight, of course, is a big one, I think. Checking a BNP if you're fortuitous enough to be able to have a lab that you can check more than once and compare that same patient's baseline BNP to one that you see in exacerbation. That'd be wonderful. Also being able to listen, being able to tell intrathoracic impedance off a device is even more helpful. And then looking at heart rate variability is also another sign of impending heart failure. And being able to control that, not only see it, but understand it, is another area that we need to investigate further. So when we look at body weight and right ventricular diastolic pressure, the COMPASS trial group looked at this. The problem there is that often the body weight doesn't shift dramatically before you get hospitalized, nor does it afterwards. We obviously diurese patients in the hospital, changing that baseline. But we're really looking at the sensitivity of just, what I tell patients all the time, 3 to 4 pounds or 2 to 3 pound weight gain over a day, that may be enough, but it isn't. And if you're waiting for their legs to get edematous, that may be even worse surrogate. So we see that sensitivity numbers are super low, despite what we're using for that body weight correlation. Looking at the .HF trial as well, monitoring impedance with audible alert, well, it actually increased heart failure exacerbation and hospitalizations. We used intrathoracic impedance guidelines from Optival at that time, looking at this trial. And that audible alert did improve mortality and actually increase hospitalizations, potentially because it's making patients worry more, but not necessarily helping them with mortality, which is the surrogate that we're always trying to use. When you take a look at these graphs, you can see why. And in fact, after about a year and a half or about 15 months out from this trial and randomization, you'll notice that the access arm actually had more deaths than the control arm. And when you take a look at hospitalization, it is tremendously separating out from day one, really. You see it separates out and never looks back. So that's interesting as well. So when you're managing pressures in a heart failure patient, it's, again, difficult to do. We know what we try to do. We want to look and get stable numbers. We want to correlate this to when they are decompensating and understand what these numbers mean. We try to get them a baseline number and use a hypothesis of determining how much above and below this is meaning that their weight is up, they have heart failure coming on board, or you've over-diuresed them and we lay off. When you looked back at that COMPASS trial, we just talked about it, and which was a prospective multi-center trial, again, looking at 274 sick heart failure patients, increases PA pressure was actually what preceded heart failure exacerbations and hospitalizations, not body weight. Body weight was pretty neutral, but really the RV diastolic pressure and filling times was really the most significant thing, which kind of perks your ears up for the CardioMEMS that we talked about earlier. And also understand that higher chronic PA pressures increase the risk of future events as well. So there's the CardioMEMS, and it really does offer a new promise. Now, it has been out now for many years. However, it has not been available everywhere. In the United States alone, it's recently was taken out of the hands of many operators in let's say about a third of the country, because the insurances from the federal government, that's Medicare, did not cover it until they realized that it really is a life-saving device. That altered the landscape and also probably hurt a lot of patients out there who had severe heart failure and potentially met their demise because of the fact that this device was not available to them anymore. But understanding from the trial data itself, from Champion, which is a landmark trial itself, CardioMEMS prevents acute decompensation, effectively lowers PA pressures acutely, lowers hospitalization rates and readmission rates, which is very important, as we talked about earlier, and improves quality of life as well. When you look at the Champion clinical data, it is amazing. The effect of the pulmonary artery pressure-guided therapy overall was huge in terms of lowering mortality and morbidity. You took 550 patients, and they're basically randomized to these two arms. And when you're able to use the PA pressure to guide your therapies to the patients just did better. And understanding there's a 33% relative risk reduction in hospitalizations in the treatment arm, which was very, very impressive in itself. Furthermore, when you take a look at it, by targeting the PA pressures, the overall mean PA pressure is reduced. And as we said, that is really crucial to determining and preventing future hospitalizations in itself. So when you take a look at number needed to treat from some of the landmark trials over the last couple of decades, beta blocker being at the top of the list, number needed to treat to prevent one heart failure hospitalization was 7, which is not only respectable, but amazing. Aldo antagonists were 7. CRT was 7. Beta blockers from a couple of other trials were a little bit higher at 15. ACE inhibitors also were important at 15. Aldo antagonists, again, from the Ephesus trial, instead of being in the Ross trial, was 16. But still in the same real category, that they're all super helpful. But if you look at the bottom, PA pressure monitoring from Champion over this 18-month period showed significant reduction in the hospitalization rate. And the number needed to treat was less than 2. So that was very, very significant. If technology can get into our hands of physicians that are able to put this in patients that are sickest, we may really, really make a huge dent in that rehospitalization number as well. Another interesting point of the Champion trial was the fact that heart failure with preserved ejection fraction, again, diastolic heart failure, you wouldn't think that this would be helpful. Why would it be that helpful? In fact, it was hugely helpful. There was a 50% reduction in hospitalizations. Again, that was very, very important to understand that and know what was going on. And when you look at mortality data, all-cause mortality, and even in patients with the best therapy that there was at the time, which is a biventricular ICD, got added improvement with the PA pressure monitor with CardioMEMS. In fact, not only a small amount, it was 64% reduction. If you did everything you could, which was guideline-directed therapies, biventricular device, and then you added the CardioMEMS and determined whether or not it was helpful, it was significantly helpful, as you see there. So looking at the management of heart failure data, there's a lot of data as we have more technologies out there. And luckily, with COVID and other reasons, remote monitoring has gone up. And that's something I think that is crucial, because that is the future. That's something that is going to say. But we have to know what to do with this data. And we need to be able to improve our algorithms with this data and understand how we can help ourselves, listing a few things, including arrhythmia burden in the top chamber, in the bottom chamber, looking at PVCs, looking at biv pacing percentages, and correlating that with a predictive model of when that patient may go into heart failure. Throwing this up here to show you that there is real-time data that is obtained from CardioMEMS. We can see exactly what their PA pressure is there, both systolic and diastolic, often using diastolic as that was the gold standard in those trials. But we can see what's going on the last day, hour, week, and that's what's great. We can treat heart failure as it's happening, not in the rearview mirror, which is what we've done in the past. A couple of more examples in trending out what we collect, showing if patients are active or not and what not. Brings us to the last technology I want to talk about tonight, which is HeartLogic from Boston Scientific. It is an integrated algorithm and technology that is part of their ICD platforms and their heart failure devices or the biventricular devices. And because we knew that there needed to be something more than just what we've already mentioned. And I think if you can summarize it all and put it into a package, we want to blend physiology where it meets technology and diagnostics, and then to figure out how best to treat that patient. But heart failure treatment is so reactive because symptoms are so reactive. Again, we look for signs, but the signs are often too late, and then the patient gets hospitalized anyway. So when you look at HeartLogic, it was going to not only use what we already knew from all the other vendors and all the other devices, but it was going to use other physiologic sensors in one single composite index to figure out this patient, something's going to happen, this one not, this is what we need to do, so on and so forth. So we have that composite, and we take a look at it. We also have sensors to pick up on heart sounds, S1, S3, thoracic impedance, which is already a part of all our platforms as it is, but is an important one in itself, even if it's late. Respiratory rate and volume, how much activity have they done? Are they laying in a chair all day? These are important things. And lastly, heart rate variability at night is a very important one. And kind of taking these 5 physiologic points and putting them into an index is actually very easy for the common person analyzing this data, as not everybody has their own specialized heart failure clinic. This is very helpful to them as well. When you looked at the multi-sense study that validated the HeartLogic, it had a very high sensitivity, 70%, for detecting heart failure events, and more importantly, a very low alert burden, as sometimes alerts occur so often that patients may be pointed to initially, aside from the stress and anxiety they get. Later, they may tune in out. It's the boy who cried wolf fable that we know about. And that is an issue because if you get desensitized to that, it does nothing for you in order to come into the clinic early enough so you can prevent a hospitalization. And again, what's also very important is time to prevent patients from getting hospitalized, give you enough time to reverse what's been going on physiologically in the patient's body. And the index here has actually in this study showed weeks advance notice of a potential heart failure event, which is amazing in itself. There also was its ability to identify high-risk patients, the stratification there as well. It was 10 times higher heart failure event rate when it was in alert versus out alert, which makes sense, but 50 times higher when it was in alert and the pro-BNP was elevated, which makes sense, but augmenting that with a simpler alert system tends to make this better. There was a very low non-alert rate of 0.08 per year, patient year, and the predictive value was very robust across a diverse subgroup of patients as we listed here. So it's exciting with what we have. The future brings us lots of new technologies and algorithms that I can't wait to incorporate into patient care. And also in the future, we want to be able to create new algorithms that incorporate what we already know, sounds, arrhythmias, and being able to bring all that together. And also incorporating data from the device, including CoreView or Optival and other thoracic impedance, with also the latest activation that you get, QLV from the LV lead. I would love to see a dynamic QLV coming up on the screen so I can understand how best to help this patient. And I would love for the device itself to be able to use QLV, determining what it needs to activate and take that into account, but also the high threshold that may be occurring from certain pulls from the lead itself. Having automatic adjustments of EV and AV, kind of in a way that's already occurring with Sync AV, but going further with that would be amazing. Having adjustments based on cardiac output calculations, which is in the works already inside of CardioMEMS. Technology is already there, it just has been black boxed out because it wasn't FDA approved, it wasn't part of the original study, but it is hopefully coming soon. And being able to use a patient advisor module, AKA a phone really these days, with the apps that allow patients to assist with management. We're already seeing it with Medtronic and Abbott already with their Bluetooth devices, the remote monitoring that they don't have to plug up or put onto themselves. The future, again, is very, very bright, which brings us to my last slide and some final thoughts. We want to strive for the best possible response for all patients, and then we assess them over and over again because patients change. We change. Physiologic changes occur all the time in patients that changes the landscape. So we need to be diligent about it, be patient about it, and keep striving for the best and really look ahead. What is it not available today may be available tomorrow. Checking a basic 2-view x-rays we talked about way back when to make sure the LV lead is in the right spot would be wonderful. CRT optimization with echo should be done at least, on that first check within the first month after getting a CRT. Usually they say within first 3 to 6 months after that. And really annually, if you're doing great, every 6 months you're not. Looking at the different algorithms, whether it's adaptive CRT, CKV, or multi-point, these give us not only a small start, but really a good head start into the arena of heart failure therapy for difficult non-responding patients. Consider HIS and left bundle where they're needed. Again, CRT versus HIS or CRT versus left bundle. There are some trial data out there, but I'll say the jury's still out. And because of that, formulate your own flow chart of understanding who gets what would be very important as well. And then consider other devices such as CardioMEMS, or if you haven't already put in a heart failure device for the patient, consider a HeartLogic device as well, as that has all those other physiologic sensors in a patient that may be ultimately refractory. Patient that's refractory to meds may ultimately be refractory to all the traditional therapies as well from CRT. So that basically wraps it up. Thank you so much for inviting me to this meeting and for paying attention and listening to this very important conference and topic as well. Again, it is an honor to be part of this. And I do pray that each and every one of you continues to stay well and healthy so that we can help others as well. And I hope I have the opportunity to come back and talk on another topic within heart failure or else, or other topics as well, as I do love being able to be amongst my colleagues around the world and be able to solve some of the problems that we have in heart failure and other areas in cardiac care as well. So with that, thank you very much and have a wonderful day.